This is Selma Schimmel for the group room at the San Antonio Breast Cancer Symposium. Joining us now is Dr. Larry Norton, Deputy Physician-in-Chief for Breast Cancer Programs at Memorial Sloan-Kettering Cancer Center, Medical Director of the Evelyn H. Lauder Breast Center, and Scientific Director of the Breast Cancer Research Foundation. Hello again, Dr. Norton.
Good afternoon. Good to be here.
I'm thinking about how different the patient role has become over these years, and the challenges. There was a time of that very paternalistic relationship between patients and doctors, where you'd go to the doctor and the doctor would say pretty much black and white to the patient goes home and does what the doctor says. And then came the evolution of the advocacy movement, and I think there's a very significant dynamic shift of a kind of a partnership that's never really existed before, where suddenly the empowered patient and the motivated advocate is also further changing the landscape. Would you speak to that?
Oh, no question. That's an important part of it as well. Is empowerment issues is really very, very important. And they're very complex because it's not just a simple thing of the patient now having some power shifted to them in terms of clinical decision making, because fundamentally they don't have all the information. Very often the doctor doesn't have all the information necessary to make clinical decisions. Clinical decisions are not just based on A goes to B goes to C. They're not very linear. They're often very complex. They're network decisions. We have to take a lot of things into account. The very best doctors also have intuition, which we haven't been able to quantify yet. I did a radio program not too long ago with some neuroscientists talking about the biology of intuition, and we don't have that figured out yet. The meeting between doctor-patient has to be a meeting of equals with different areas of expertise. The doctor knows more about science and medicine, sometimes, although I've had doctors and scientists as patients, and that adds another level of complexity to the conversation. But the patient is always an expert in their own life. And the doctor doesn't come close to understanding the complexities of the patient's own life. And good medical decisions have to be a meeting of minds of really two equals on the best path forward, always, no matter how simple sometimes the situation has to be. And that means that the physician has to have enough confidence in herself or himself to be able to surrender some decision making to the other expert in the room. And the patient has to have enough confidence in themselves that they can walk that fine line between being irrationally demanding, and kind of making decisions that they're not qualified to make, and also just totally being submissive and saying, I'll do whatever you tell me to do. There is a fine line there, and I've seen mistakes really on both ways. Of people just saying, whatever you say, I'm going to do it. I'm going to follow you sort of blindly and not bring forward information that could help modify that position. But I've seen the other side of it too, saying, that's just ridiculous because that's just crazy. I've seen often medicines have. That's used for one thing can also be useful in something else, because that in that regard as well. And I've seen patients not take medicines because they say, well, this is a medicine for feet and my problem is my hands. What does this doctor know about? Forgetting the skin is skin, and therefore not doing something because they think they're more expert than they really are. That's a mistake too. There's a very fine line. It's actually being successful in a doctor-patient relationship is a skill set that people who haven't been sick before don't necessarily know that. One of the key things that I constantly am telling my patients in that regard is that you have to be aware of one thing that's really very, very real when you go to a doctor with a problem. Because often the patient goes and says, this is my problem, and they're expecting to hear the best thing to do is this. And instead, for the most part, what you hear is, what I could do for you is this. And to hear the doctor's area of expertise saying, I can offer you this operation, I could offer you this medicine, rather than the answer that you want to get, which is the best thing for you is something that I actually don't do, or that I'm not very good at, or a medicine that I don't have available to me, and this is where else you can go for it. And that's one of the hardest things to hear in a doctor-patient communication. That's also a consequence of the fact that there's just such a diversity of approaches that's available now. There's no uniform approaches. That many of us who try to put together guidelines, for example, think in our own minds there may be 2 or 3 options, but actually when you investigate it, nationally, internationally, there may be dozens or hundreds of options because of the diversity of opinions. It's that fragmentation of society thing that I was talking about before.
And stepping out of the exam room, there's a whole new role with patient advocates and physicians at a time where I believe that physicians need patients more than ever, and I'm not now talking in the exam room, I'm talking in the research setting and in the public policy arena, and I've been fascinated watching these new alliances and the respect that physicians are showing to the patient advocacy community, recognizing that in order to propel research forward, that the need of the advocate community is greater than ever.
Absolutely, and some of the great revolutionary things that's happened in the last couple of decades have been because of very involved advocates, but there is one thing that's very important for the advocacy community to know and to recapture. When you're talking to policy people, when you're talking to medical people, to scientific people, what really moves people is data, information, and not opinion.
Or emotion.
And that, and I could get very emotional about data too. So that's an important part of it. If you really want to move things, all right, then the statement "I think," or "the people I represent think," or "I have a feeling that," or "I feel very strongly that," all right, is not going to move things as fast as, we have done this survey and we've spoken to these people, we've looked at outcomes, this is our data about outcomes, and I call this advocacy research. And there's a tremendous opportunity for the advocacy community to embrace that particular role, especially in an era where we're talking about comparative effectiveness research and we're talking about doing outcomes analysis as a way of supporting the results of randomized trials. I mean, part of it is the subjective part about how people feel, and also the objective part of how it affects their lives. And those things generally don't get measured. And those things, we don't really have data on that because the wrong people are asking the question. And we've actually done this ourselves. You can get very different answers to the same question when you're talking to somebody depending upon who asks. Whether it's a doctor, whether it's a nurse, whether it's an advocate, whether it's somebody that the patient recognizes as a member of their community, that they speak a common language and they have a common history. One can get very different answers to the exact same question depending upon who asked the question. And that has to be looked at as well. And certainly, somebody who's going through an illness may give a very different answer to a question when they're talking to somebody else who has been through the illness or is going through the illness than they would to somebody who they think is the other. It's the concept of the other. And so that is a role that I'm not seeing the advocates do enough, and I would really encourage them to do it. If you can actually come forward with real data, information, something concrete, all right, that is gathered by the unique resources that they can bring to the problem, that can really move the agenda, and that is something that I would like to see much more of.
Thank you, Dr. Norton. This has been, for me, a huge privilege to spend time like this with you. Thank you so much.
Thank you.
Dr. Larry Norton, Deputy Physician-in-Chief for Breast Cancer Programs at Memorial Sloan-Kettering Cancer Center, Medical Director of the Evelyn H. Lauder Breast Center, and Scientific Director of the Breast Cancer Research Foundation.